everyone, and welcome to the Surgical Ergonomics podcast, where we will be discussing everything related to surgical and procedural ergonomics, the people, ideas, and technology that will help enhance your physical wellness and career longevity. I am your host, Geeta Lal. I'm an academic endocrine surgeon, speaker, consultant, and surgical ergonomics coach. Having experienced work-related musculoskeletal injury myself, I am committed to increasing awareness of and developing solutions to counteract the impact of poor ergonomics on the professional and personal lives of healthcare workers in procedural areas. Hello, everyone, and welcome to another episode of the Surgical Ergonomics podcast. I am delighted today to have as our guest Dr. Ian Soriano, who is a general gastrointestinal and bariatric surgeon and actually serves as the current director of robotic surgery for the University of California, San Francisco Department of Surgery. Dr. Soriano's research actually focuses on using laparoscopic and robotic techniques to reduce both surgical complications and improve patient outcomes. He also studies ways to support the longevity of surgical careers via robotics and ergonomics, and is a highly regarded speaker on this topic, both nationally and internationally. Welcome, Ian, to the Surgical Ergonomics podcast, and thank you for sharing some time with us and also your expertise.
Of course. Good afternoon, everyone. And Geeta, it is a pleasure and my privilege to join you today.
Wonderful. Okay, so just to get us started off, I was wondering, Ian, if you could tell our listeners a little bit about yourself, including kind of your training background and how you arrived at your current roles. I ask this because I'm also, I'm not an international medical graduate, but I grew up outside of the United States and then came to Canada for university, etc. So I know that your journey has been kind of long-winded like mine. And so I was just wondering if you could share that.
Sure, my pleasure. As you mentioned, I am an international medical graduate. I completed medical school at the University of the Philippines in '97. Challenging couple of attempts through the match as an IMG. I successfully, finally obtained post-match positions as a prelim, followed by a categorical in Philadelphia in 2001, where I finished my residency in 2006 at Einstein in Philadelphia, followed by a fellowship in minimally invasive and bariatric surgery at the Cleveland Clinic in Florida. I then did a year in private practice before realizing that academic surgery was something I really was missing and passionate about. And so since 2008, I have been a faculty member, primarily in Philadelphia, where I practiced for approximately 15 years, with the last
Mhm.
6 years being at the University of Pennsylvania, where I was the chief of gastrointestinal surgery at Pennsylvania Hospital, which is one of the three main teaching institutions of the University of Pennsylvania health system. In 2021, I moved to UCSF
Mhm.
and joined the Department of Surgery here. And approximately 2 years ago, I was named director or appointed director of robotic surgery. I've been doing laparoscopic surgery primarily since 2007 as a surgeon, not as a trainee, since fellowship, and started doing robotics since 2012. So approximately a little bit over a baker's dozen now.
So that's interesting. So you actually didn't train doing robotics. You learned robotics once in practice.
If I were to look at my case mix at this point, I would say
Mhm.
that about 40 to perhaps 50% of my cases are done robotically, with the other half being a mix of open and laparoscopic approaches. I still do a fair amount of open surgery given the case mix and types of cases that I do.
Okay, sure. Thank you for clarifying that. So I want to tell our listeners that Ian, Dr. Soriano, was actually part of our core group that started the surgical ergonomics interest group early on in the pandemic. I think it was around the time that you moved that we actually became a full-fledged society, and you chaired or co-chaired the education committee along with Pam Hess initially. So I'm familiar with a little bit of your story, but could you share with me and your listener and our listeners how you actually became interested in this topic of ergonomics? Because many of us came to it through our own injuries, myself included.
Yeah, so I think I came into it fortunately not because of injury, but probably because I wanted to prevent myself from getting them because I was feeling aches and pains on my shoulders and back after long days in the OR of doing laparoscopic surgery, particularly for bariatrics. When I was in Philadelphia after fellowship, I would say that about 70% of my practice was bariatrics.
I
And
see.
so, with long days in the OR, performing laparoscopic gastric bypass, sleeve gastrectomies, doing laparoscopic surgery, dealing with thick abdominal walls, creates a lot of torque and a lot of force needed to
Hmm.
perform those procedures. I wasn't really knowledgeable about how to optimize my position or the position of the bed or the position of the patient. And so it started me into looking as to how I could be better. And then, as a couple of years later, as I learned about robotics, I saw that even though I was sitting and my shoulders uh, were not, and my legs were not standing, even the robotic console itself had its own set of limitations that had changed the ergonomic stresses on my body in a different way. And so I
Yeah,
think
yeah,
it's very important for our listeners to make sure that it starts from having a good foundation. And I say that because it actually starts from where we plant our feet. And in case of robotic surgery, where we plant our butt when we're sitting
yeah.
to create a good foundation for the rest of our body when we're
Okay.
operating.
Well, no, this is all very, very important information. And I want to tell our listeners that what you've heard Dr. Soriano say is crucial for whatever kind of surgery you're doing. And Ian, you brought up some points that I want to highlight. Okay. So, number one, minimally invasive surgery, whether you're doing, and first you started doing laparoscopy in any field has been independently shown to be a risk factor for the development of work-related musculoskeletal disease among surgeons. So it doesn't matter if you're doing laparoscopy, thoracoscopy, hysteroscopy, whatever sort of oscopy you're doing, even if it's endoscopy, you're going to have a higher risk of pain at any site as well as fatigue. You mentioned one reason for it, which is sort of different torques. One advantage of laparoscopy is that you're not bending over an open field and you're looking at a screen, but then you're introducing, as you said, these different sort of conditions where you're holding these instruments. What are some of the other things that make straight stick laparoscopy or traditional laparoscopy so ergonomically challenging?
Well, I think you said a couple of things there that triggered a couple of things in my brain.
Yeah,
First would actually be surgery is a team sport, right? It's not just
yeah.
about you. And unfortunately, oftentimes as attending surgeons, when we set up a room or set up the bed, we think of ourselves only, not thinking of our assistant. So the height of the bed plays a big role in creating ergonomic stresses, not just on you, but the team. And so setting the height of the bed at the right height as low as possible, accounting for the tallest person in the room, I think is going to be very important, right? And then planting your feet not on the floor, but on what has historically been called a princess mat, right? Because initially it was women who asked for it, but and I can tell you, a lot of my partners when I was at Penn, we asked for it routinely because it made a big difference when you're doing a long laparoscopic case, being able to stand on a pressure mat that would help relieve some of those leg stresses, right? So that's one. Then I think the second stress that a lot of surgeons don't recognize when they're doing laparoscopy is eye strain. Like that distance from the monitor to your eyes should be within about 3 feet, about 2.5 to 3 feet. Anything longer will stretch your eyes and create a lot more eye strain. And so that's actually very important to have that monitor at the right distance plus the right height. You don't want that monitor to be above your line of vision so that your neck ends up in a hyperflexed position for the duration of the case. Otherwise, you're going to be spending that evening asking for a lot of packs and a lot of Motrin and Advil.
No, I hear you. I hear you. You know, again, for people listening to this, Dr. Soriano has brought up all these key points about positioning, right? So he mentioned the screen, which is a source of ergonomic stress. So having it at the right height at eye level and at the right distance is important. Having the table at the right height is important for you. Now, in open surgery, we say it should be at or just below elbow level, depending on kind of the height of your patient. Your working field should be at elbow level. How does that change with laparoscopy, Ian?
Yeah, so it actually, since you have longer instruments that you work with,
Yeah,
right, and it also depends on where your are positioned, it might be different. And so you have to adjust it based on how those ports and your operating position is for your arms. And so it could be quite
right,
variable, but in general, it probably is at about the same height as lowering the head, the level of the table, so that your shoulders are not elevated but are relaxed when you're operating, and your arms are just below 90 degrees, and then your wrists
right.
are also at neutral position.
Right. So it sounds like then we want to have because we're using instruments, longer instruments, we want to have the table maybe at like 80% of elbow height so that once you're holding the instruments, as you said, you're not having to shrug your shoulders up. They're still kind of, your forearms are at right angles to the floor or slightly, kind of facing the floor, but not sort of up, if you will.
Yeah. You don't
Okay.
want that praying mantis position when you're operating.
I've seen pictures. You're right. It does look like a praying mantis when we do that. So these are all well and good, right? But I remember when I think I finished medical school maybe just a little bit, a couple years before you, and I started as a resident. And I remember when we were doing, getting trained in sort of lap choles, etc. The Our staff surgeons told us that the gynecologists were the ones that were doing a lot of laparoscopy for a long time, and then the general surgeons were kind of later adopters. And then I found out that actually the laparoscopists, meaning the gynecologists, were the first to raise the alarm regarding injuries from laparoscopy, particularly as it pertains to hands and relating to instruments. So when we were talking about like what are the stressors for laparoscopy, I think instruments are a huge deal, right? And in
Yes.
particular, things like graspers, staplers, things like that.
Yeah, so we haven't even gotten into what's in the box, right? We just started with the
Right.
head and the neck, and we started with our base. And now let's
Base.
focus on what's in the middle. Regarding instruments, so the first generation of instruments in laparoscopy, they were not rotating tips. And so to rotate the tips of the instruments, the surgeons had to rotate the handles themselves. And so that would put them in a very non-ergonomic position. So that would be the first. It was also a little bit later on, probably in the second or third generation, that locking
Mhm.
instruments were developed. So if you can imagine, prior to that, a surgeon had to grasp whatever they were grasping and put a death grip on it in order to keep it in position for the
For
duration of the
hours.
case, if they
Yeah.
had to, in order to maintain that position. The development of laparoscopic retractors was also something that came later on. And so that
Mm,
also was something that helped alleviate some of those stressors. And then I think one of the things that probably is now being more recognized, and I credit our society with initiating this study about a year and a half or 2 years ago, was that for the first 15, 20 years of laparoscopy, majority of instruments, the grasping width of the instruments, which were mainly pistol grip, meaning you had to
mhm.
hold them in a way that as you would grip a pistol, were designed for surgeons who had at the smallest grip a size 7 glove, which was majority of the gloves for male surgeons, despite the fact that it started with GYN, which is
Hmm.
quite interesting. And so that became the basis of the development of a lot of laparoscopic instruments, whether it was graspers or staplers. And staplers being
Hmm.
heavier, wider, and thicker handles were also more challenging to grasp. Later on, the development of inline graspers,
Hmm.
meaning they were in line with the long axis of your extremity, made it easier to grasp these instruments. And then they became locking and also rotating. Did some of these stresses become alleviated?
Yeah, yeah. So clearly, this is listeners, we've just heard a history of the development of laparoscopic instruments. And I certainly remembered, death grip on the grasper, the first generation graspers, and then it became much easier as we went along. But I have to admit, I don't have size 7 hands, and we actually discussed this hand size study that we've been doing as part of the Society of Surgical Ergonomics on the inaugural episode of the podcast that we did with Dr. Hallbeck. The key thing that she pointed out and that you've just pointed out for our listeners is that your grip strength changes if you're using the extremes of your hand span to generate that grip, right? So if the instrument, even if it's in a more comfortable reticulating pistol grip, if it is at the extremes of your hand span, you're not going to be able to generate the same amount of force. And that's the reason probably why a lot of smaller handed surgeons, and I'll say who happen to be female, they don't have to necessarily be female, but who happen to be female, like myself, had trouble closing laparoscopic staplers, even the second generation ones. And then, of course, as you said, there have been additional advances in terms of kind of getting the inline instruments where you don't have to use that kind of force to use them. Now, these are all well and great. Clearly, industry's listening, and there have been advances, but we haven't really touched upon one of the big things in laparoscopy, which is the staplers and stapler handles and the different kinds of staplers. And you were part of this webinar that the Industry Collaborations Committee of the SSE held in December. And for people who are interested in more depth information about staplers, they can go to the SSE website and take a look. I'll include the link with the show notes. What can you share about laparoscopic staplers with our listeners on this podcast?
Sure. Similar to the development of laparoscopic instruments, the initial generation of laparoscopic staplers were also developed with the basis on the basis of a size 7 glove in terms
Hmm.
of its grip. And then as time developed, there were some innovations that allowed you to actually close and fire the stapler with less force by the way they created the closing forces of that stapler. But I think that the biggest advancement in stapling, laparoscopic stapling development was the development of what we call powered staplers. And there are different types of powered staplers on the market. There are
Hmm.
hybrid powered staplers, and then there are the purely or completely powered staplers. What I refer to as hybrid staplers are those that require still a manual force to
Hmm.
close and to close the stapler jaws prior to firing the stapler.
Hmm.
And one example of this would be those manufactured by Ethicon. Those still require manual closure, but firing the stapler cartridge to close the staplers over the tissues is done in a powered fashion. This is different from that produced by Covidian, or Medtronic, which is a completely powered stapler, where both the actuating mechanism can actually change the tip or the angle of the jaws, open and close the jaws, as well as fire the entire stapler cartridge.
All of those are fully automated. Is
Those
that what
all
you're
of those are
saying?
fully automated. Yes, that is correct. So that's a fully powered stapler.
Now, from what I recall, what we discussed in the webinar, Development of these powered staplers was actually stimulated by outcomes in patients as they related to stapling and variability in stapling among practitioners. How has the development of these automated staplers changed the ergonomics for the end users, or have they changed the ergonomics of end users?
You know what's fascinating is in theory, I think it has, but it's fascinating that none of the manufacturers have actually published any studies specific to
Hmm.
any improvement in ergonomics related to the use of the staplers. I guess for the Ethicon, since the handle between the powered and the non-powered staplers are the same, there's no difference. But for Covidian slash Medtronic, I think it would benefit them to actually look at how users find the handling and usability of their powered versus their manual stapler. Because most of this were, as you mentioned, driven to create consistency in the formation of the staple line
Hmm.
because
Hmm.
the deployment of the staples were now done in a standardized fashion versus
Hmm.
before the speed of deployment, the the pressure on the staplers during closing was quite variable. With the
Yeah.
powered staplers, that has now been made completely automated.
So it's interesting that you point that out, that there's actually no study. So I'm going to call upon an informal survey. So you're part of a number of minimally invasive surgeons and surgical societies. What is your informal survey tell you about the ergonomics related to automated staplers? I realize that there's no published work, but the theoretical advantage that you mentioned, is it really there?
I think it is there because you're grasping just the handle. You don't
Hmm.
have to grasp the handle plus the actuator that extends out from the handle. So there's
Hmm.
no handle that has to be closed. You're just
Yeah.
grasping the handle plus the button that's at the tip of the trigger that is at the
Okay.
upper part of the handle. So I think in
Okay.
theory it should create a better ergonomic environment for the user.
Do other surgeons, when you're talking, do they feel the same way? Or is this just your opinion?
No, I mean, my partners all use the powered stapler, and they're our physician assistants are two of them are female, and they
Mhm.
both use this with no issues whatsoever. They're very happy with its use. No one's complained of, finger numbness or tingling in their fingers. So, I mean, this is very informal, obviously, but I think it is
Yeah.
worth looking into.
So that's what I was kind of going to ask you next is that, for our listeners and trainees who are learning laparoscopy, working with these instruments. They've tried all the things we've talked about, correct setup, etc., but their hand anthropometrics are such that they're still struggling with the use of laparoscopic devices such as staplers. Is it worth investing or at least trying out automatic staplers? And from what you just said, it sounds like it might be. Then comes the issue of cost, right? Because when you try to ask to trial these instruments, obviously there is a cost differential. And how much of a cost differential is there? Would it offset, surgeon injuries and the cost associated with those?
I mean, if we were a bean counter and we looked at every single dollar, right? But we forget to account that you're prolonging the life of the surgeon you just hired, who paying a salary for, or you just invested all this time and money in recruiting. Plus,
Hmm.
also, if you look at the consistency of a fired staple line and how that theoretically or potentially can reduce the likelihood of a leak or any other complication, then I think it does even out. If you look at the raw numbers, for
Hmm.
example, for at least Medtronic slash Covision, which is our vendor here, the cost difference, surprisingly, is actually under $200 for using a powered versus a manual stapler.
Interesting. Wow. So over time, it sounds like the cost differential has gotten smaller,
And
and
I
at least for that vendor that you mentioned.
Yes,
So
and
okay.
that might be just because of our contracts. Obviously, UCSF is a big
Big.
organization, they might have bigger contracts, so it might be different for other organizations. But I do think that if you were to really look at how these vendors are trying to price them, I think they are looking at to make them as competitive as they can because they
Hmm.
believe that it does have that clinical benefit.
Okay, so it started out as having a clinical benefit, but may end up benefiting the end users whose hands are on the instrument at the other end. Obviously, that needs to be studied. So, any of our up and coming trainees, listeners, students interested in ergonomics, here's a research project for you, right? So, all very fascinating. Now, Ian, you made the shift to robotics. And, whenever I give talks on surgical ergonomics, and maybe you find this too, there's invariably a few comments in the chat or certainly in the Q&A period when people start asking, well, just switch to the robot. Everything's better with the robot. What are your thoughts on ergonomics and robots? You touched upon it a little bit earlier because, yes, you're sitting and now you're not standing for hours. So, what are the challenges of ergonomics at the robot, and how should people do what you mentioned for laparoscopy, meaning, set up, being aware of their postures? What are the tips and tricks that you want our listeners to know and want your trainees to know?
Yeah, I think as you mentioned for laparoscopy, it starts with your foundation or what you're putting your base
Hmm.
on, right? And so for
Hmm.
robotics, it's not what you're standing on, it's what you're sitting on. Find the
Hmm.
right chair. The right chair can make a
Hmm.
big difference when you're doing a robotic case. If that seat is too high for you and it's putting your knee at an angle that's either too high for it or too low, you're going to have some pretty either bad knee pain or bad ankle pain. So that would be number one. The second is also setting up that elbow rest to make sure that you are also, again, at either a neutral or neutral position or one that keeps your shoulders at a neutral height and not elevated. And then lastly is postural resets, which
Hmm.
in robotic parlance means ABC. Always be clutching because you can't
Mm.
help having to move your hands or your fingers up and out as you're manipulating. But if you
Hmm.
don't clutch, next thing you know, you'll be operating again like a praying mantis because
Mm.
you're all over the place. So postural resets, or in this case of robotics, clutching allows you to bring your fingers, your wrists, your elbows, and your shoulders back to a neutral position, allowing you to have no or minimizing prolonged ergonomic stress.
I see. Now, you mentioned, having the strong foundation. Is whenever I'm seeing people at robotic consoles, I'm amazed at the kinds of chairs people use, right? So it's like some random OR stool, one that doesn't lock. Then I've seen people put blankets behind things. It seems like there are a lot of workarounds. And a lot of people don't realize that the console actually comes with a chair that was actually designed for it by a chair company. Advice for picking the chairs for the robot. And I realize it's not perfect, but what would you tell our listeners about that?
Find one that locks, number one. Number two is find one that would have some elbow rests because even though your forearm is resting on that elbow rest, it sometimes does move back. So you may want to
I
just
see.
put up, some additional surface for you to be resting your elbows. And obviously one that has really good back support, not one of those circular chairs where you don't have good back support. Those I think
Mm.
are very important. Obviously, you've got the fancy gaming chairs out there that provide you full spine support, and that would be nice to get those. But I don't think that the hospital's going to support paying for those fancy full spine support chairs in the OR. But who knows, right?
Yeah, yeah. Now, what about the viewfinder, right? So that seems to be a huge pain point, right? And although there is the next generation of the most common robotic platform on the market, which has made improvements in terms of, the mobility of the viewfinder, a lot of hospitals still have the older version and will for a long time, and it'll be hard to get time on the new platform for many people. So, is there a sequence of things that people can do as they set themselves up at the robot that would help? this pain point, where to get that finder.
Yeah, the first thing you want to do really is set up your chair so that your knees, your lower leg, and your thigh are at about 90 degrees. So you're not
Foundation
leaning,
first. Yeah.
you're not leaning forward. You're not falling over and putting a lot of your weight moving forward. And then at
Okay.
that point, you want to keep your axis of your body sitting up straight. But and here is the issue, as you had mentioned, with the XI console. It is at its max. There is no neutral position on the XI console. It is preset to a max of about 10 degrees of flex. So it actually does put your neck at about a 10 degrees of flex, no matter how you try to put it up. So that actually is
Hmm.
the most flex you can get with it. So I would actually put it at its highest available flex. You don't want it to keep on being more flex and putting a lot more strain on your neck. That is the advantage of the new DV5 that actually allows you to be in a completely neutral position and be able to fully immerse yourself in the console without straining your neck during the procedure.
Those are all good points. And again, I'll just reiterate because Ian has mentioned this multiple times. And so we want to make sure you understand. Start with the foundation first, right? Don't pull that viewfinder in first. First, get yourself, based correctly, and then the viewfinder. Any other tips? For example, in open surgeries, laparoscopic surgeries, we're often talking about taking breaks and doing postural resets. Is that still important at the robot?
I do think so. Absolutely. I think no matter
Okay.
what approach we're doing, whether someone's doing cystoscopy, someone is doing an open procedure, laparoscopy, an open procedure, I think at any point during a procedure, if you feel any kind of stress on any portion of your body, take
Mm-hmm.
a 15, 20-second break. It will do your body wonders. It could actually also make that surgery go quicker because you will be less
Yeah.
stressed. And as that procedure goes longer, it does benefit not just you, but actually your entire team to remind everyone take a postural reset. And that's something that, particularly if you're doing robotic surgery, don't just
Mm-hmm.
to forget to set up the console. Make sure that you set up the bed for the procedure so that
Right.
your bedside person, is not in any way also compromising their ergonomics. Because the way the robot arms are positioned, that monitor might not be in the best position for them to be able to help you while also compromising their ergonomic position.
Yeah, I'm glad you brought up that point because I was going to ask you about that. I gave a talk to physician assistants about 6, maybe 8 months ago, and that was their concern, right? Because they're at the patient bedside. And their question to me was, well, how do you tell surgeons to position this so that I don't keep getting knocked about with these arms, right? So, do you have any tips or tricks before you sit down at the console yourself to ensure that your assistants will be comfortable?
Well, so one thing is I do make sure that my assistant does have a chair at bedside if
Okay.
possible, right? So that they're
Mm-hmm.
also not standing for the entire procedure. Number two is so if you can position the arm so that it does not get in the way of the monitors or gets in the way of them providing you assistance, because the
Mm-hmm.
arms have a lot of maneuverability in
Mm-hmm.
terms
Mm-hmm.
of how it enters into the patient, but you can actually move the upper arms further out, but still have the same positioning on the inside. So there's a way,
Okay.
so if you can adjust that beforehand, then that would help.
Mm-hmm.
And then lastly, obviously, a lot of rooms used for robotics and laparoscopy have more than one monitor. So set
Mm-hmm.
up
Mm-hmm.
the accessory monitors in the room so that your assistant can have their neck and their head in a neutral position for the duration of the case.
Right. Yes. So please pay attention to the laparoscopic part of the robotic procedure for your assistant's sake. All good and great advice. I remember when I was coaching with my partner, one of the biggest sort of high yield stretches they mentioned for the robotic surgeons. A lot of the surgeons actually said they put their arms up on the viewfinder and kind of just stretch exactly their upper body But she also did something what's called an executive stretch. She pointed that out. We don't have the gaming consoles, but you can put your arms, both your arms, kind of with the fingers locked behind your head, so at the back of your head, and just kind of lean back and
Yep.
stretch back, right?
Yep.
Because we're all getting that upper cross syndrome, right? Leaning forward,
Yeah.
everything in the back and everything in the front is tight and everything in the back is weak. So all great information and advice. I think I call this like gold nuggets for surgeons, to prevent long-term injury. Any other tips and tricks, for example, port placement? You work with bariatric patients and our patients' BMIs are only getting larger and larger. Tips or tricks to position patients and how to place ports.
Yeah. So I think it's not the BMI, it's the thickness of the abdominal wall that matters.
I see. Yes. Okay.
You could have a patient with a BMI of 40, but a very thick abdominal wall, and you could have a BMI of 60, but the abdominal wall thickness is thinner,
Got it.
right? So that is actually what matters. And
Mm-hmm.
so if the abdominal wall is thin, it's like you're operating on a normal sized BMI patient. But if the
Mm-hmm.
abdominal
Mm-hmm.
wall is thick, you have to direct your trocars towards your target organ. Or if you're working in two quadrants, to target it between
Mm-hmm.
those two quadrants so that you don't have to fight that abdominal wall thickness during the procedure. And also to make sure you position the bed in a way that exposes your target organs before placing your ports rather than afterwards, so that you have to fight the thickness of the abdominal much less.
Got it. What do you do for the laparoscopic portion of the robotic cases or your open laparoscopy when it comes to foot pedals? Do you still use them or do you try to get like a hand cautery attachment?
Oh,
Because
yeah.
I visualize your praying mantis, but I think of myself using the foot pedals and I'm often in that, flamingo posture, with the one leg up. So,
Yeah, so once I saw the advantages of that finger actuated Bovi without having to use the
mm-hmm.
pedal. I have
Pedal.
not used the pedal at all for laparoscopy in so many years. And that applies to all energy devices that I use. They're all hand activated because trying to activate a pedal that you can't see, that you have to look down
Mm-hmm.
while you're
Mm-hmm.
keeping your eye on the operating field is puts a lot of more stress on you as a surgeon and a lot more ergonomic stress on your body as well.
Okay. Folks, you heard it here first. This pearl of information from Dr. Soriano. Try to get all your devices to be your energy devices, especially cautery. Say no to the foot pedal if you can.
Oh
Huge,
yeah,
huge, yeah, huge.
finger actuation. And speaking earlier, you mentioned about the executive stretch. One other stretch I do at the console is actually
Mm-hmm.
holding the console and then turn my body while keeping my torso straight, but turning
Mm-hmm.
my entire body and holding the ends of that console on each side to stretch my sides as well. So that's another stretch I like doing at the console.
Right, right, for your spine as well. While we're on the topic of the stretches, what do you do for your hands and wrists, if anything? Because, when you look at the data for robotic surgeons, and this is published, yes, there's lower incidence of low back pain. There's still significant neck pain, and we discussed why. But now you start to see like hand and wrist issues that maybe you don't see with open laparoscopy as much anymore since we've had advancements in instrumentation. Any tips for where folks can find these exercises and do them?
Well, I think one of the things we always refer to are some of the Mayo OR stretch exercise videos that we are
Hmm.
also available on the SSU website. And then I also, having some exercise balls, the squeezers that we
Mm.
can use are very helpful. And then obviously stretching your fingers below each surgery. Don't crack your knuckles. That is not what I do, but just
Yeah.
stretching them out in between cases is also very helpful,
Hmm.
right? You want to do the intra procedural stretch and also the inter procedural stretch. So between cases and during cases, this is
Right.
stretching every single part of your body that feels like it needs a stretch.
Right. Thank you for that. And for our listeners, I'll enclose these links to the OR Stretch app, just like I have in other episodes. And the American College of Surgeons also has their ergonomic recommendations, which have both, intra-procedural and interprocedural stretches. So you have plenty of resources. These are all free. And as Ian mentioned, you can also take a look at the Society of Surgical Ergonomics. Now, Ian, before we sort of try to wrap up and close here, I want to tell people, I know you mentioned the princess pads or the anti-fatigue mats, and this is such an important topic. So I'm actually going to dedicate a whole podcast episode to building that foundation with anti-fatigue mats, share the data that's out there, as well as, talk about footwear and like, the clogs versus running shoes. So that's a future episode. But for now, what I want to do is say to you that I'm amazed at whenever we chat about these things, how the time I've set apart for a recording just marches and flies by as it has again today. And I am so grateful that you're doing the work that you're doing and that you've given us time today to share your expertise and tips and tricks. I'll make sure to include your contact information in the show notes so people can reach out to you if they'd like to learn more from your experience. And thank you so much again for being invested in surgeon wellness and surgical ergonomics.
It was truly a pleasure. Thank you for the invitation. And to the audience, thank you so much for finding time to listen to us. And always remember, always be clutching.
Please remember to subscribe to the podcast and follow us on social media, Instagram, X, Facebook, and LinkedIn. We love feedback, so please reach out to us for topics, ideas, speakers, or if you ever want to be a guest on the show. Thank you for listening.